Hello, everyone. I wanted to welcome you to this Commission on the Status of Women forum titled The Future of Caring, How AI is Transforming Nursing. I just wanted to give a brief introduction of myself and my fellow moderator, Jenna Marquard. I am Martin Michalowski. I'm a School of Nursing Foundation Research Professor at the University of Minnesota. I am a computer scientist by training. My broad research area is in artificial intelligence and more specifically automated reasoning. And I've been in the School of Nursing for almost 8 years now. I'll give Jenna can introduce herself.
Yeah, my name is Jenna Marquard. I am also faculty in the School of Nursing at the University of Minnesota. I'm a professor and the chair of one of our, what we term them cooperatives, our Population Health and Systems Cooperative. My background is really at the intersection of health informatics and human factors. And so most recently, I've been thinking a lot about how we can design AI that best supports end users, whether those are nurses or physicians or patients. So I'm particularly interested in those types of issues, and I'm so thrilled to have the panelists here today.
Great. Thank you, Jenna. So before we get started, I just wanted to kind of put this forum into a little bit of context and give very brief background. I will go quickly as I'm excited to hear what our panelists and speakers have to say today. So really, you know, in my view and in others that you'll be hearing about today, AI really plays a role in what I would term to be modern nursing. It really is applicable across many aspects of nursing. For example, enhancing patient care. We see a lot of real-time monitoring, early diagnostics. There's a lot of work around reducing workload or burden and automating various tasks. Uh, a lot of research that I do in medical decision making, medication management, reduction of human error. And then there's a lot of recently a lot of talk around using generative AI to help with documentation, summaries, and patient education. So AI is really important. It's here, and it will be a major component of nursing moving forward. There are several key areas that it already is impact and will continue impacting in the future. Some of these are listed here, such as diagnostics, virtual nursing assistant, uh, personalized treatment that uses AI. And then again, as we'll hear about and as we hear about in the news and elsewhere, a lot of generative AI work that helps nurses drafting reports or patient instructions or training materials. But of course, with any relatively new implementation, there are challenges, and there are several challenges that I think are important to acknowledge and that need to be addressed as far as the implementation of AI in nursing. The first is as kind of I've called here the human touch in care. So. Uh, AI cannot replicate what nurses do at an emotional level, from a compassion perspective, bedside manner, all things that are critical to nursing. There are quite a few ethical and privacy concerns around the use of AI in practice, and these revolve around the handling of patient data, compliance with various frameworks and policies and regulations. There are biases and over reliance or decision making risks that are potentially exacerbated or introduced using AI on medical data. Uh, there's also, as I mentioned, this possibility of an over reliance on an AI rather than using critical thinking skills. and potential skill gaps if there isn't sufficient training available. And finally, AI tools need to work. They need to work well and seamlessly and not add additional burden or complexity to existing nursing workflows. So just as a final kind of looking forward, I think it's important really to emphasize that AI is a very exciting, broad set of tools and methodologies that are meant to enhance nursing and not replace it. I think there's a lot of trepidation around these technologies taking over. And I think that that's the wrong perspective to take. I think that it really should be seen as a collaborator rather than something that replaces. So, this manifests itself in multiple ways. So, we talk a lot about AI automating routine tasks, but compassionate care is still a uniquely human trait. Uh, and so nurses can also use AI to improve their decision making, but they still have expertise themselves that's needed to make the optimal decisions around treatment for a patient to that leads to best possible outcomes. Um, we can't talk about AI without talking about generative AI and Chat GPT and many other versions of it. So these tools are incredible at enabling and supporting communication, training, optimization, but there will still be a place for human intuition and places where these very large models aren't the best approaches or need help. And really, in that sense, I think the future does lie in working with the AI and nurses working together with it and using them as supports and not a replacement of care or of caregivers' roles of a nurse's role. So again, kind of the key takeaway, AI is an incredible tool. It's very exciting. It's changing rapidly. Uh, but nursing and nurses have many, many traits that AI, at least yet, or maybe never, will be able to replicate, and hence this collaboration. So I'm going to quickly thank everybody for coming. We're not done, we're just getting started. But please feel free to reach out to Jenna or myself if you have any questions or to the speakers themselves. I will put a quick plug for a Nursing and AI Leadership Collaborative that the speakers you'll hear about today and myself have started that is really working towards this AI nurse collaboration and trying to push the profession forward. So the website is here. And speaking of our speakers, we do have four very exciting and very well respected speakers with us today. I will introduce each one individually. They will talk for about 15 minutes. And then we encourage you to use the Q&A feature in the webinar to ask any questions. We'll allow about a time for maybe one or two questions after each individual talk. And then we'll have time at the end to do kind of more of a panel discussion where we'll address any new questions or any questions that we didn't get to during the talks. So I will stop and I will introduce our first speaker. So let me just briefly read a bio. So we are honored to welcome Dr. Laura Maria Peltonen, an expert in nursing informatics and digital health transformation. She is an associate professor at the University of Eastern Finland and a key researcher at the Wellbeing Services County of North Savo. She is also affiliated with the University of Turku and serves as a visiting associate professor at Warwick Medical School in the UK. Dr. Peltonen plays a pivotal role in shaping digital governance in healthcare. Her research focuses on developing intelligent solutions for healthcare delivery, ensuring that digital innovations align with nursing practice, workforce needs, and patient-centered care. And with over 100 publications, she has led interdisciplinary collaborations across academia, industry, and policy, driving AI integration and evaluating its impact on staffing performance and patient outcomes. So please virtually welcome Laura. I'll stop sharing.
Thank you very much. And thank you, Martin, for this presentation and for the opportunity to be here. Sorry, I activated my Chrome AI at the same time. Sorry for that. So I'm going to share my slides here. Excuse me. Let's see. Slide sharing. Here we go. And if you can confirm that you can see my slides here.
Yep.
Brilliant. So yeah, I'm very excited to be here today in this event. I think it's an amazing event you've organized, and I'm going to talk about how nurses can shape AI to transform global healthcare. And I thought I'd just start to focus on the context of nurses, like not go straight to the technology side of it, but looking at what nurses are and how the nursing space and landscape looks like from an international perspective and also from a healthcare systems perspective. So we have about 60% of the healthcare workforce globally are nurses, and this is an amazing portion of the people working in this space, but also they are very important to health systems, not only for the work that they do professionally and recognized, but also the work that they do beyond these recognized societal roles. Altogether, we have more than 30 million nurses and midwives, and that's a lot. And it's a workforce that's moving around, a mobile workforce globally. So every 1 of 8 nurses would work in another country than where they were born. So this is also something quite interesting in terms of how this looks like and where we can apply technologies as well. So 67% of the health and social workforce are women, and this is in connecting back to the topic of women here, and 90% of nurses are women. So this is a highly populated field by women, I would say, and there are also studies related to those. We won't go into more detail about those today, but in that perspective, there are specific applications that AI would also support within nursing and beyond. I think I also want to highlight the current challenges we have in nursing and in healthcare globally. So I think the biggest crisis currently are the shortages. So it's a global emergency by default that we do not have enough healthcare professionals, and the numbers are getting worse. So we are facing an increasing shortage of healthcare professionals overall, but also nurses. And at the same time, we have challenges with the health and well-being of the workforce. We have a lot of burnout and challenges with recruitment and retention of the workforce. At the same time, we see health systems struggling with funding and the policy around that, which changes and makes it even more difficult. And we also have a global health crisis in other forms, like the pandemic we just experienced, but also the increasing challenges that climate change brings up on us, and also the aging populations and different kinds of chronic conditions that increase the needs of services. So all of these things are making nurses work even more demanding, and we have challenges in like staying up to date with the things we have today, but even the future looks worse, and situations are going to be getting increasingly more difficult. So we do need solutions for making our health system sustainable from a global perspective. So AI promises a lot, and I think for us, it's very important to think how these technologies can help nurses in a way that's meaningful, effective, impactful, and we have a lot of ideas where we could apply these technologies. So, as Martin already mentioned earlier, a lot of possibilities, but also we can look at them from different perspectives. Some of these have more sophisticated needs in terms of the technologies that we would like to apply, and others would manage with more simple solutions. But altogether, we can apply AI on different levels and for different roles and different contexts. So I think clinical practice is the most the biggest field, biggest landscape for these applications, and patient care, direct patient care, care assessment, monitoring, evidence-based decision making, care coordination. These kinds of situations would be primary focuses for applying these technologies, but also from the end user side of the patients, the service users, chatbots for self-care support and guidance for people living at home. And then these tools that Martin also referred to, different kinds of support for information management, from collecting the different types of information, storing them, summarizing, retrieving information, but also in terms of the global space and migration of our workforce, we can think these translation technologies are very useful in terms of communication between professionals, between the nurses and the patients and their families. So there are ample opportunities in terms of clinical work where we can apply these. But also competence development. So we have done some studies where we used some AI in our education and found that to be quite useful, but also professional development and so forth. Leadership and management surely will benefit from monitoring systems, different kinds of ways to measure and assess performance, and scheduling and resource allocation, for example. So many opportunities that we can think of. I wanted to bring a very, very simplified, so this is a super simplified figure of illustrating a technology development process overall. The point with this figure is to illustrate how we typically develop our systems that we apply into healthcare. And usually our end users, the nurses, they would be involved somewhat in the testing phase, so quite at the end of this technological development phase. And this brings quite a few challenges in terms of how this technology will look like and how it's going to function. So ideally, we would like to involve the nurses earlier in this process. Martin also referred to this technology or the need of this technology to fit in this space of the users. For the nurses, it needs to be functioning quite nicely. And we have already some research on AI applications. It's not, we don't have evidence of the impact of AI technologies, of the newer technologies like generative models or the large language models yet. But still, we have experiences from clinicians and from nurses that they have challenges with trusting these systems. There are issues with reliability and trustworthiness that they report. And although we have a lot of promise with the potential of these technologies, we are still sort of looking for the evidence to demonstrate the real benefits of these systems. So nurses are generally open to the idea of using these tools, in particular in in the care of patients with chronic conditions and such, but there is still some resistance to this as well, which also highlights the importance for us to invest in education to help nurses understand these technologies, how they function, and help them sort of evaluate how to use them safely. But in addition to that, we need to figure out systems in place, infrastructure, ecosystems that enable and support the nurses in their work to have these technologies applied in a safe and ethical way. So these ethical, legal, social implications, how these technologies, how they function, how they fit with the workflow processes of the clinicians, of the nurses, that's very important if we want to get their full benefits, but also if we want to get the buy-in from the nurses. Otherwise, we'll develop tools which they are not interested in using. If it takes more time to fix the problems that the systems make than doing it out the system, then they won't buy into it. So that would be wasted resources in the development and the implementation process altogether. But one key thing is like developing the competence, as I just said, and that would relate to both like the skills and knowledge around these technologies, but also the attitudes. So we don't want to take technologies that do not function into these environments and let the nurses down, but rather develop these technologies far enough so that they actually are beneficial in clinical practice. So we need a very broad perspective in this development, and the nurses need to be involved. Nurses have an in-depth understanding of patients' needs, nurses' needs, healthcare service processes, and all of these different perspectives that will be useful when we start planning and prioritizing what kind of technologies we need, what the problems are that we want to solve first, and how to do that. So it's an interdisciplinary, even transdisciplinary effort that needs to be in place and ensure then that the technologies will make sense when they are developed and applied. One of the reviews we did a few years ago showed that like only 1% of the technologies, AI technologies that have been applied into nursing actually stay operational. So we do a lot of development and testing and only a little bit of implementation, and very few technologies actually at the end of the day end up helping the nurses in their work. So this is one of our studies that we are doing currently, and Martin also was talking a bit about this. So this project is called Profit, and we are looking at different kinds of needs and bottlenecks where we could apply AI technologies and support the nurses. And as probably is quite evident at this point, the documentation burden that currently is in clinical practice, it's varies from 40, 50, even up to 50, 60% sometimes. So they use a lot of time on this information management in their work, the nurses, and we need to figure out ways to support them. So we have been looking at different challenges, different opportunities, and what we can do to support the nurses and this documentation process. We are recording care situations, we are recording information as it's collected, and then we're transcribing it. We are doing different kinds of structuring methods and thinking about how we can improve the quality of the data and then get that data stored in the EHR. And then we'll apply different kinds of tools such as summarization methods and information extraction methods to help the nurses manage that data and try to support their work and reduce the administrative burden that comes with these systems, as an example. So, some key takeaways from this presentation, perhaps. AI has a lot of potential in nursing and to support nurses. And supporting nurses will support the sustainability of the health systems, as the nurses represent a very big deal, a very big part of the healthcare professionals. Still, we do not have a lot of evidence on the impact of these systems, because these systems, some of them are quite new, and generating that evidence will take quite a long time. In addition, these research designs that we are needed to evaluate these AI applications in clinical practice, they're quite costly and they take a long time because they are very complicated as well. But we will need more information about, of course, considering the ethical, legal, economic aspects of these technologies, but also keeping in mind this environmental perspective, because we can make choices that influence what kind of an environmental impact our technologies will have. We do not need to use more than necessary. Another point of view perhaps is like nursing and what the role of nurses are in terms of safeguarding the patients when we apply new technologies into healthcare. Of course, we do have and need more robust legal frameworks around applying technologies in healthcare, but nurses also have a role of being the patient's advocate. So all of these perspectives come together to they actually bring a lot of requirements in terms of the knowledge and skills needed in nursing now and in the future as well. So we really need to revisit our curriculums and improve the level of competencies around AI and bring these kinds of infrastructures around into clinical practice that enable the support for nurses to engage with technology development and implementation processes and ensure that we have the support and guidance which is needed. So altogether, I would like to conclude with just thinking that if we invest in our nurses to become AI leaders and help them engage with this technology and implementation, then we actually support our communities worldwide. So thank you very much. This was my talk, and I think I'm going to give the word back to Martin. Thank you.
Oh, thanks, Laura Maria. I am so thankful for your presentation, and it prompted quite a few questions for me. And I want to make sure that participants, you can also be sending things in the Q&A, and our panelists can answer those perhaps while they are or after they're speaking, and I'll moderate those. My question for you was, you started out with this idea of one of the current challenges really being global workforce shortage. And so there's these parallel conversations about the workforce shortage, but then also kind of anxiety about AI replacing nurses. And so I wanted to get your perspective on how you reconcile those two distinct concerns that feel like they're a little bit at odds with each other.
Mm-hmm. Yeah, thank you. That's an interesting question. So I think we do have a global shortage, and it's increasing. It's looking worse. So we need to come up with solutions to respond to that. And from my perspective, AI is one opportunity that can actually help our health systems become sustainable. In terms of the idea of being afraid of AI, I think we tend to be afraid of things we do not understand. So I think investing in understanding what these technologies are and increasing the competency, the digital literacy, the understanding of AI technologies and what they can do and what they cannot do, I think that would be the first step to sort of influence this thought around AI replacing jobs. I'm sure AI is transforming healthcare delivery in many ways, but there will still be a lot of things to do. They will just look different. So we will always need the nurses to do the nursing, but things that we can and should automatize, we can use AI for that.
Perfect. No, thank you so much. Martin, I'll hand it over to you to introduce Max.
Great. Thank you again, Laura. That was great. So we'll move on to our next speaker. We'd like to welcome Dr. Max Topez, a leading expert in AI and healthcare innovation. He is an associate professor of nursing at Columbia University and a pioneer in applying natural language processing and AI to healthcare data. His groundbreaking research focuses on developing AI-driven solutions for clinical decision-making, text and data mining, and automated speech processing. With over 170 publications and a research profile exceeding $20 million in funding, Dr. Topaz has significantly advanced the integration of AI in healthcare. He also brings expertise in health policy, leadership, and entrepreneurship. His clinical background includes internal and urgent medicine, and he holds a PhD from the University of Pennsylvania, along with a postdoctoral fellowship at Harvard Medical School. So please give a virtual welcome to Max.
All right, what a great introduction. Thank you so much to the panel moderators for having us. So I'm going to talk about the rapid acceleration of AI in nursing. And for me, this is a call for action. All right. And so, talking about AI, this presentation was created with AI. All the images you would see are created with AI. That's a nice AI tool. It's called Gamma. And that's what we're looking at today. All right. So briefly, we are undergoing, as described by the previous speaker, we're undergoing an AI revolution in nursing. And AI is accelerating at an unprecedented phase. There is rapid deployment of AI in healthcare. And, from my perspective, that's what I want to argue today. It remains unchecked to some extent. And as nursing and other healthcare professionals, we must act now so we can shape AI to make it fit what we need it to do for our patients. So a personal journey in AI that's going to exemplify this transition and rapid acceleration. So when I started my PhD in 2010 at the University of Pennsylvania, I worked on developing an AI tool. It is the first generation of AI tools of this type, basically taking data from the electronic health record and identifying patients at risk for rehospitalization. And specifically, the tool looks at patients who are coming out of the hospital, going to home care. So we identify those patients that need care the most. And then the idea is to send a nurse within the first 24, 48 hours to visit those patients in the home and provide care as soon as possible to prevent deterioration, prevent rehospitalizations. So it took about 15 years for us to test this tool in a clinical trial. So the development took several years. That was my dissertation. Then we did several pilot studies. We then have gotten a large clinical trial study from the National Institute of Nursing Research to test the tool and see if it really affects patient outcomes in an efficacy trial. Now, we did all of that. Again, it took 15 years. The tool is somewhat outdated by standards today, but we see that it works, and the next steps for this would include rolling it out in a larger place. So we did testing at one very large home healthcare agency in New York, but we need to do further testing with this to see how we can apply tools like that in a wider array of settings. So that's one caveat. It took 15 years for us to get done with the first clinical trial. So here are some publications just exemplifying this timeline. So we published in 2014, published one of the first articles that are describing the tool. 2016, we did a pilot work where we saw positive potential impact on the outcomes. In 2021, start the clinical trial, and 2023, and right now we got to kind of finish that and see it through. Again, in kind of limited setting, looking at the effectiveness of the tool. All right. What the tool does, basically, it takes information from the electronic health record automatically about patients, Specifically, it extracts patient demographics, diagnostic codes, functional status, medication records. So all of this information is captured in a way that's structured. So, it's written there using codes, using drop-down menus, things like that. Further, when I was on my postdoc at Harvard, I was one of the pioneers to apply natural language processing on data generated by nurses. About 8 years ago, we started this path going towards integrating data that's generated by nurses in a free text format, right? So as a clinician, you would write your clinical notes in a free text format. So it's just text. And then we need some kind of technology that's going to be able to analyze this text. And what we're doing, basically, we're applying artificial intelligence to be able to analyze those texts. And what we see is that nurses document important things. Nurses document, for example, patient symptoms like shortness of breath, social determinants of health, like problems with money, problems with transportation, etc. And then all of those are having an impact, are associated with negative outcomes. So it took us about 8 years to have a study that's developing tools like that. So we just finished a large study funded by the Agency for Healthcare Research and Quality, where we developed a tool like that identifies patients at risk for deterioration based on the nursing data, extracted from the structured data, so the fields that I showed before, codes, and free text clinical notes. So about 8 years, right, to develop a tool like that. So that's one of the final publications on this tool, building a time series models to predict hospitalization risks and home healthcare, insights and development, accuracy, and fairness. All right. We've done lots of natural language processing studies working with texts, focused on falls, for example, focused on dementia symptoms, focused on home care risk factors, focused on stigmatizing language. So all of this work has been done, relatively recently. Now, about 4 years ago, we said, hey, there is a whole new aspect of interaction that can be captured and processed by AI systems. And I'm talking specifically about a huge data piece that was previously uncaptured and unused. It's a verbal interaction between patients and nurses. So for the past 4 years, we've been working on analyzing this verbal interaction, so recording verbal interactions between patients and nurses, and then applying AI on this data to identify risk factors, to help document things automatically, things like that. Again, this grant, we have a large grant right now working on that, funded by the National Institute of Aging. It's the large grant we started about 2 years ago, and we're just in the midst of trying to deal with all of this data, the verbal data, the present problems that people discuss with their nurses, the fact that about 50% of the problems that are discussed between the patient and the nurse are not documented in electronic health records data. All of that has to be dealt with in some way or another. We're just starting to think about that. It's relatively recent. And so this is one of the publications that's coming out of this line of work, utilizing patient-nurse verbal communication in building risk identification models, the missing critical data stream in home healthcare. All right, the next frontier we just started working on is analyzing video data. So AI has gotten so good that it can analyze video data. So here you can see an example of work we're doing with Dr. Michalowski. And we are seeing a patient on the left-hand side. And then we are basically asking an AI to answer different questions, like analyze the video to determine what kind of shoes the patient is wearing, assess whether the shoes provide adequate traction, support, or stability, say yes or no, or insufficient information. So AI systems are increasingly capable of doing things like that. This is a very recent capability that emerged in the last year or so. And we're starting to explore how it works and what it is. However, with generative AI, especially in the last couple of years, there was a rapid acceleration of AI capabilities, what this technology is able to do, right? A good example of the video analysis that the technology is able to do right now, wasn't able to do it a couple of years ago. Now, here you're seeing an application of ChatGPT on analyzing data. So I'm asking ChatGPT to generate data, fake data for these purposes, or synthetic data, and then it will create visualizations. It will do the data analysis. It will ask me about different things in this data analysis, and then it will proceed to write a report, write an article with all the needed sections. So the power of this technology has become incredible in the last year and a half or so. So here, for example, the table is being generated about this data, and then the next steps here would include analysis of this data kind of review. All right. With that, we hear, so this relatively untested technology, generative AI, is being rolled out in the field. So about 30% of US physicians, about 40% of electronic health record vendors are starting to pilot and starting to use this technology of speech recognition, for example. Sometimes it's called ambient listening, where the technology would listen to you, talk to your patient, and then document things. So this is being rolled out at an expanded pace. However, multiple questions about this technology, we just started asking those questions, and we don't know what vendors, what companies are going to do when they implement this technology. How are those questions going to be answered? So in terms of science, we're just starting to do that. However, the field advances super rapidly. And so one example is that clinical conversations, we see that 50% of the problems are not documented in electronic health record. For many of those problems, it makes sense, actually, because we cannot act on everything the patient would tell you. We need to choose the most important, most critical things. How would AI do that? We're not sure. So things like that are very concerning. So when I get to think about that, a couple of things come to mind as I round this up. So a couple of solutions. We need to have an open mind towards this technology and have places where we would share experiences. So people who are interacting with this technology would share their use cases, and we would discuss them, review them, try to understand how is this technology working or not working for us in nursing, and how this technology benefits our patients. So having something like a simulation lab where AI technology is going to be tested briefly, and we are going to find pitfalls or ethical issues with this technology, we have to have those. We have to be AI watchdogs as nurses. We have to see and understand what AI is doing to our patients, and from multiple perspectives, ethical, clinical perspectives, we need to be able to judge that, and we need to be able to stop things that are not appropriate and support things that are appropriate. All right, expanded AI literacy, the previous speaker mentioned that. And then, of course, policies focused on AI integration into practice, how to do things appropriately. So the few takeaways: AI technology accelerated rapidly in the last couple of years. It's being applied in the practice, and we need to do something about that. This something is a multi-aspect thing that we need to do, including policy, rapid testing of AI systems, and we need to remain vigilant, analyzing these AI systems as they grow. All right, and this is all for me.
Oh, thank you so much. And I was really struck by, and thank you for your framing of the real need at many different levels for nurses to be actively driving these conversations and decisions. I have a little bit of a two-part question that you can help me untangle a little bit. So I was struck by the comment in your slide about implementation happening faster than validation and the need to speed up the validation process and make sure that these tools are doing what we hope they are. So I had a question about the first part of the question is, are there people who are explicitly focusing on approaches to more quickly validating these tools? And then the second piece of that is, how do you think about validation at a sort of local setting versus if there's differences for validation between different practice settings, and what that might look like? So if you can kind of tease apart that two-part question.
Yeah, thank you, Jenna. Great questions. Very briefly, the first one, are there people who are focusing on, doing something about that, right? This integration. There are very few research teams that are dealing with that, and we hope, the interest grows and, finding whatever public attention grows. With this growth, right, we expect to see more people interested in that and doing this line of work, but there is not much, right? And this is also a very specific expertise that not many people in nursing would have, right? And so we do need an interdisciplinary collaborations for that, things like that. So we're not seeing much of that. This is being done by companies now, which is, concern, and the healthcare systems, right, which is nice. So it's usually what I see, those ambient listening technologies, for example, right, are collaboration between the electronic health record vendor and the healthcare system. And, they kind of hack it together, which is great, but like, there's big questions to answer there. I'm not sure in terms of clinical needs are very different from what we can do in research, right, and the kind of the angle that we take. So there's this. Now, so your second comment was about, things we need to do, as far as I have gotten that, things that we need to do to make evaluation of this technology, right, to make it kind of better for us and for nurses and, and eventually seeing this technology through that it does help improve patient outcomes. So we do need, my take on that is that we do need a multidisciplinary collaboration to help spearhead that. So it's great that we have people in our NAIL collaborative, for example, with different backgrounds. And this is all of those perspectives, legal perspectives, ethical perspectives, technical, clinical perspectives. They're all needed to be able to start addressing some of those issues that are emerging. But again, the technology moved so quickly that we do need to develop new mechanisms to be able to address that and deal with that.
No, I really appreciate that answer. And again, folks can put questions. It looks like there's already a couple questions for Max in the Q&A, and he can take time during the next speaker to go ahead and answer those. But again, I really appreciate your perspective. Thank you.
Yes, thank you, Max. Great presentations as always. So I'd like to introduce our next speaker. So we're delighted to have Dr. Lizanne Prunelli, a distinguished leader in nursing informatics, data science, and AI. Dr. Prunelli is an associate professor at the University of Florida's College of Nursing with a joint appointment in the College of Medicine's Department of Surgery. Her expertise lies in leveraging big data and AI-driven models to enhance patient outcomes, particularly in transplantation and chronic disease management. Dr. Prunelli has led cutting-edge research in predictive analytics, collaborating with institutions across the U.S. to develop smart clinical solutions. She is a fellow of the American Medical Informatics Association and one of the co-founders of NAIL. Additionally, she co-chairs the Nursing Knowledge Big Data Science Initiative and serves in pivotal roles with organizations such as IEEE, AAAI, and AI in Medicine. With over 100 peer-reviewed publications and a strong presence at national and international conferences, Dr. Prunelli is shaping the future of AI in healthcare. So please join me in virtually welcoming Lizanne.
Thank you, Martin. Let me share my screen. So thank you for the introduction. I would like to extend my thanks to Dr. Jacquard as well for the invitation to speak here today. My presentation will provide an introduction to a holistic view of the drivers for ethical AI in healthcare. So I would like to start with this sentence that is associated with the Hippocratic Oath, with most of us made when entering the medical profession. Here, I use as a start point for us to think as a principle for an ethical framework, not just as healthcare providers, professionals, but also as an AI-enabled healthcare system, as we see now shaping in that direction. So when we think about the care that we deliver every day to our patients, we deliver an uncertainty care. And why I say that? Because if you remember how we start building knowledge in how to care for people, if you remember in the past, that is how we use it to educate medical professionals. And then we started doing open surgery and everyone was seeing things. Then we started having bigger and bigger rooms where we had more students observing a procedure as a way of educating. Then we start moving to more artificial experiments. Instead of testing as the first picture on the bottom left, we start having mannequins instead of humans. Then now with the technology, we start moving to a more virtual environment for that education. Then I question how our brains are shifting this way of thinking and how we need to change as well as we learn in a different way what we have been used to learn for decades in a totally different way. And you may think, why I'm talking about this in an AI nursing webinar? Because I believe that is the start for us to think how we build these models to actually be successful when we are implementing them. When we think about uncertainty, I usually like to think about how our care is about not having 100% certainty about the prognosis of what the patient's, the trajectory that the patient will have. Is a probabilistic approach, because we have the probabilistic direction of one or another when patients ask, what will happen with me next? This is crucial for navigating complex situations and making informed decisions, and we are very well aware there. This approach also acknowledges that absolute certainty is often not untenable and utilize probability theory to manage and communicate uncertainty. And then ultimately, we can enhance patient care and safety. When we move forward and think about AI in healthcare, we cannot forget about these basic concepts, as may help us to understand how to better deliver AI-driven system for care delivery that we can actually have the buy-in of the providers that will utilize those systems. The integration of artificial intelligence into healthcare research specifically presents exciting opportunities for advancing diagnosis, treatments, and patient care management, as we saw in the previous presentation, some of these examples. Alongside, however, these advancements, ethical challenges emerge, ranging from privacy concerns to bias and accountability. To responsibly harness AI's potential, a structural ethical framework is necessary to guide its implementation in research and in clinical practice. Several frameworks exist. I'm showing this one because this is the closest probably to my heart, because it's based on the centric core ethical principles, what I believe we need to think when we use AI. that is respect for autonomy, justice, beneficence, non-maleficence. And that is everyone that works in healthcare know those principles. So we don't need to get so outside to learn new principles, to start learning how can we use those basic concepts to start thinking about how can we build and deliver an ethical AI framework. AI relies on large-scale patient data, raising concerns about privacy, security, and informed consent. Well, that was already mentioned before. Biases in models can disproportionately impact healthcare outcomes. A question that was raised before, how can we actually evaluate those systems that are being implemented in healthcare systems, particularly for populations that are rare cases or that are underrepresented in the population, rural populations where they don't have that easy access to healthcare. Without transparency in decision-making and clear accountability measures, public trust in AI-driven healthcare solutions may erode. An ethical framework serves as a structural guide to mitigate this bias, ensuring that AI in healthcare research is both effective and responsible. This specific framework, we can see the core ethical principles in the center, operational guidelines, around that, and then outside, all the implementation principles is in the bottom is the reference for that framework and the further explanations about how that works. This framework is built upon the 4 fundamental ethical principles in medicine, as I said before: respect for autonomy, beneficence, non-maleficence, and justice. These principles are widely recognized in medical research ethics and provide a strong foundation for guiding AI development and application in healthcare. That is what I believe. And please disregard if you don't believe the same. This is my own perspective. Respect for autonomy, what that means in AI, ensures that patients and research participants, or even clinicians, have control over their data and fully understand how AI will be used in their care. Beneficence, AI should maximize benefits, improving healthcare outcomes, while ensuring safety and reliability. Non-maleficence, AI systems must be designed to minimize harm. Remember the first slide, do not harm, preventing bias or errors that could negatively impact patient care. Justice, AI-driven solutions must be equitable, ensuring fair access to their benefits across all populations, preventing the deepening of existing healthcare disparities and access to care. Beyond those principles, the framework provides concrete guidelines for ensuring ethical AI integration, covering areas such as transparency and explainability. AI systems must be designed to provide understandable, interpretable outputs for healthcare professionals and patients, not just in one setting, but can be replicable across different settings. Privacy and data protection. Compliance with HIPAA and other regulations must be enforced to safeguard patient data. It's easy for us to think about having guidelines. We are very good in writing consensus and making recommendations, but how we as nurses or providers are making sure that these recommendations actually are in place and are enforced to safeguard patients. Bias mitigation and inclusive design. AI models should be trained on diverse data sets to prevent healthcare inequalities. Stakeholder engagement, ethicists, policymakers, healthcare providers, and patients, and even more, must be actively involved in AI development and oversight from the start to the end. Continuous monitoring and evaluation. AI applications must undergo regular assessments, as the question was before. It's not just one time, are multiple times, and need to be updated every time that there is a mistake or that error is found to identify ethical concerns and implement corrective actions. Some of these key ethical concerns aims to address patient confidentiality, protecting sensitive health data from unauthorized access or reuse. That didn't change. We have been using electronic data, research, patient data for years, decades. We still have to protect sensitive health data. The layer that needs to be in place now is different because of the AI technology. Bias in AI algorithms, ensuring fairness and avoiding skewed decision-making, diagnosis, and treatment. I will talk a little bit more about bias later. Informed consent, developing updated frameworks to reflect AI's role in research and care, and whether patients want to provide their data to one or another type of research. Accountability, defining clear responsibility when AI-driven decisions impact patient outcomes. Who will be accountable for? Equitable access, preventing AI from worsening healthcare disparity by ensuring fair implementation. Many of these questions, I don't have an answer, and probably we will not have, but they are questions important for us to discuss and have different ways of addressing those. But we need to think and talk about those. So according to some authors, the main distinction between the draft and the final version of a publication is the new emphasis on how bias manifests itself, not only in AI algorithm, but in data and how that data was used to train these algorithms, but also is a societal context in which AI systems are used. This figure is a little bit of a representation, and I think Dr. Topas highlighted very well the many years that we spend doing something to actually deliver something. And that delivers something is usually a small picture of all the work that is behind and all the work that we have to do to prevent bias, to mitigate bias, to make sure that we are doing the correct way, to deliver the best effort that we can as an output of that work. So now I will talk a little bit about this different aspect of explainable AI. Different frameworks have been developed over the years, especially in the recent years, for explainable AI. But I like these ones because they are more like simple concepts, and I think it's easier for us to understand a little bit. So how can we explain the AI-driven process into medical terms, right? We are talking here more for a medical audience. We have the technological aspects that was a little bit mentioned before, that there are several layers on that aspect. There is the meaning from start to the end, the legal aspects, the social aspects, and the ethical aspects. So what are these technological aspects? How do we account for? However, more important than that, however, is the inherent explainability in general of how methods can be more or less accurate and how that can be explainable, right? Some people, some authors like Rudy mentioned here, has been working in this area for many years about how can we raise attention to the shortcomings of explaining how methods works, and some like approximation of other methods, like more traditional ones, as for example, regression, if we think about statistics, but in contrast to the notion of having more value given to the complex nature of explaining machine learning models, especially deep learning models, and then more currently the large language models. So I think this is some of the things that we need to think that beyond performance, right? Performance is something, but every time that someone says, my model predicts 99%, I'm very worried about that. Because even the most exact clinical trial, you cannot have 100% certainty. Then you use a machine learning model and you get 99% predictivity. Is very confusing for me, thinking about how the data works. So the legal perspective. the legality of this process, right? The data is acquisition, storage, transfer, processing, and analysis. We have to comply to laws in all these layers, right? That is even before we start even building and delivering a model. There are several steps that we need to follow. There are regulations and legal requirements that we need to follow. In the absence of general rules, right, how we use personal data information, how we use informed consent is the standard for today's, as we used to do before. What physicians and nurses should do to provide more explainable explanations, right, around these two principles. The agent view of the AI, how it takes what is going into those models that are being implemented. What is being delivered? How do you do the interpretation of those, right? It's not just to make sure that these models are validated, but in the end, the front end worker, doesn't matter who this person is, can be the nurse, can be the social worker, can be the dietitian, can be the physician. This person needs to take into consideration the clinical case that the person has there to see if that AI model is applicable or not. That is the same case when we have a medication to deliver. Is that medication is really will have that clinical situation at that point in time? Sometimes not. Individual predictions can be safe-checked for patterns that might indicate a false positive. How unusual feature distributions are, depending on the clinical case, as I said before. Are these AI adding the risk that we are adding to this patient or not? How can we deliver different options that clinicians can actually choose? Which one is best for that patient, right? I work a lot with clinicians nowadays, and I ask all the time, what do you see this going? And they used to say, oh, at some point it will be like a medication. We have a patient with diabetes, we have a couple of options, and we will choose which one is best for that patient that has the diabetes, because it's not about the diabetes, it's about the other context around the diabetes. But then I ask, but medication, we know what it's for. Well, we know how it acts, but what is the inner aspect of how that medication actually helps diabetes? We actually don't know. We know that it's proven that helps to treat diabetes, but the inner circles, the type that we are talking before about the technological perspective, we don't know. The clinicians don't know. In the patient perspective, we have to think that, after all, doesn't matter what you do, we need to deliver patient-centered care. AI or not AI, enable care. We have to include nowadays even more patients in the decision-making and establish shared decision-making process in all this timeline of the patient. Medical facts versus AI-driven models, which is the best? I don't think neither is the best. I think both need to work together. Is how it was said before, right? We will not replace, we will add, we will be a tool, we will augment the treatment. If we cannot explain to clinicians, I ask you now, how can clinicians explain to patients what we are implementing in clinical practice? How can patients rely on clinicians if the case they are presenting for decision-making is actually not clear and the clinician don't know how to explain? And I will leave with even more questions. How can we address all these questions? I like these pictures that shows someone saying for different types of animals in different sizes that live in different situations, in different environments. For a fair selection, everybody has to take the same exam. Please climb that tree. Can we do that with AI in healthcare? Can we say, let's implement in the same way for everyone in the same way? Do you have that answer? I don't, and I don't think we can. Thank you very much. Here is my information, and please just let me know if you have ever any question. I will return this to Martin. Thank you.
Oh, thanks so much, Lizzie Ann. And I just wanted to make a comment, and then I want to make sure we have enough time for Charlene. So I very much appreciate your framing of the idea that decision making will always have uncertainty. We can't get rid of it, even with AI, and we shouldn't discard it because of that, but that we need to somehow communicate that. So I'm going to hand it over again, folks. Please put questions in the chat if you have them for Lizzie Ann, and I might put one in now, but I'm going to hand it over to Martin to introduce Charlene.
Great. And thank you again, Lizzie Ann. That was a very interesting, thought-provoking talk. So for our last talk today, I wanted to welcome Dr. Charlene Ronquillo, Filipina scholar, registered nurse, and leader in health informatics equity. She leads the Health Informatics Equity Lab at the University of British Columbia Okanagan School of Nursing, where she pioneers research on equity-centered health technologies. Her work ensures the meaningful inclusion of non-dominant groups in developing and implementing health technologies, with a recent focus on AI fairness and trustworthiness in clinical documentation and data quality. Charlene is deeply engaged in global and national leadership roles, serving as chair of the research advisory panel for the Nursing Informatics Group of the International Medical Informatics Association, EDI co-lead for UBC's Data Science and Health Research Cluster, and EDI co-lead of the Canadian Primary Care Research Network. Her interdisciplinary work is grounded in critical theories and implementation science and has received funding at both national and international levels. She has an extensive academic background with roles at the University of the West of England, the University of Exeter Medical School, and Toronto Metropolitan University. She's a very sought-after speaker, so we're happy to have her here. And please join me in virtually welcoming Charlene.
Thanks for the very generous introduction. Sharing my screen. All right, can you see that okay?
Oh,
yeah, sorry, I can't see everybody. Okay, perfect. Yes, thank you for the very generous introduction. It's always, I have the great pleasure of speaking with the panelists today on a fairly regular basis, but I don't actually get to hear everyone's talks all that often. So it's really nice sometimes in this space because things develop so quickly. I just wonder if like the way I'm thinking is kind of going off the rails a little bit. So it was reassuring to hear that a lot of the core things that kind of underlie the work that we all do remains the same at its core. And I think it actually works really nicely. I get an opportunity to kind of pick up from some of the things raised by the previous speakers around fairness and equity and explainability, in particular Lizzie's talk, which I did really appreciate kind of that framing around probabilistic understandings of what these tools can do. So I'm going to be talking about kind of ways of thinking about trust and equity in the context of healthcare AI. I have the great privilege to join from the unceded and occupied territories of the Syilx Okanagan and racialized immigrant settler on these lands, and thank the Syilx Okanagan peoples for, as caretakers of this land since time immemorial. This is just a little clip of kind of the last of our winter adventures on the ski hill near where I live here. Bias, I saw a question already in the Q&A around this. I think there's been good, robust conversation around bias already, and our understanding of the impact of those on health outcomes. So I won't go into too much detail about these studies, but these are just kind of two of the probably some of the most impactful studies that have come out, particularly the one on the left, Obermeyer study, that had shown kind of bias in outcomes across different racial groups that had led to investigation, much more investigation of the space. There's also, and Max has done some of the work around this, is illustrating the presence of stigmatizing language in electronic healthcare records. So for those of us who have clinical background, this is unsurprising. We know, if you ever worked in Emerge, for example, that the language that clinicians sometimes use in describing particular patients are not great. Sometimes can be very biased, and can reflect societal stereotypes. And unfortunately, there is evidence that these make their way into electronic health records, which then become our sources for data for building these models. So kind of where does that leave us at? So there are many challenges in addressing trust and equity in AI, some of them mentioned by my colleagues earlier, but I'll talk about these 4 things in particular. So inequitable foundations, both in terms of the structures that we've established in healthcare systems, as well as kind of the general evidence base and how we do things. They've been set up inadvertently. I don't think that was the intention, but they have been set up to produce inequitable outcomes and inevitable capture of data among different population groups. We also still, in my view anyway, have a fairly narrow view of where we think about equity in the AI development pipeline. It's still, the weight is still primarily on outcomes and, producing biased outcomes. And obviously we want to avoid biased outcomes, but I do want to talk about kind of some of the upstream things in the pipeline. And Lizzie has also pointed to some of these things earlier on the talk. A little bit talking about some of the work we're doing around balancing fairness and performance, and kind of that whole conversation around how do we weigh the trade-offs, what's an acceptable level of risk, and that kind of thing. And then factors beyond the technology itself. Again, going back to some of those upstream factors, what are the relational pieces? What are the contextual pieces that we really need to understand to be able to move towards trustworthy systems and AI that produce equitable outcomes for all. So first, beginning with an equitable foundation. So some work we did a couple of years back now, to show that generally the capture of nursing data and allied health data, at least as it's reflected in the public literature, is limited. Generally, there's poor collection and underuse of these data. Some of this is related to historical inability to make sense or analyze nursing data. So Max had talked about, the big changes brought about by developments in natural language processing, where a lot of nursing data live still. I'm in Canada, and this is still true in terms of where nursing data tends to end up. Part of the challenge as well of not having these kinds of data from these groups is we're missing important expertise, particularly related to the things that nurses and allied health professionals are really good at, like providing relational care, like advocacy, like assessing for context and environment, social terms of health, health equity factors, and that kind of thing. We're unable to link care interventions to outcomes because we haven't defined well what is nursing data, or those are not structured in such a way that have made it historically easy to analyze. It's difficult to link them then with health outcomes and care delivery outcomes. And this is actually, in my view, a big gap in knowledge in this space. And then downstream, these limit the possibilities of AI, kind of these big gaps in knowledge and how we're doing it. There's progress now, which is encouraging, and I'm hopeful that things will move in the direction of being able to make better use of these data. As somebody had mentioned already in the Q&A, part of our inequitable foundations as well are the evidence base that we use in medicine and in healthcare are inherently biased. Thinking about RCTs, for example, or they are exclusionary in nature, which makes sense. Thinking about research design, we want to make sure we want to be able to establish, causal relationships. And for that reason, there is an exclusion of a lot of groups that are deemed complicated or difficult to control for in the context of this study. So the one study I'm showing here is one of the most highly cited that I found that showed that exclusions from RCTs due to age happened in 72% of the trials that they had. So this study was done in 2007. So of those age exclusions, 60% were in the pediatric population, 38.5% in older adults. A medical student some years back as well kind of gained a lot of popularity with the acknowledgement that assessment of dermatological conditions in terms of teaching materials are limited to light skin. And so there's kind of this lack of knowledge around, how do you assess erythema in dark skin, for example. And so my point with this is if our evidence foundation base does not reflect our populations, yet those are the guidelines for what data becomes important to collect. And our clinical guidelines, then we're shaping the data that we collect to be kind of reflecting these structural and societal biases. And so I'll talk about one of the studies where we really asked this question around trying to get at understandings of nursing documentation. How do we document? What are we omitting? What type of language are we using? What does this all mean for downstream AI possibilities? And so in this study, we spoke with nurses who provided care in the communities. So home care nurses and public health nurses. It's a grounded theory kind of methodology. And part of the motivation of this study was recognizing that for nurses who are situated in communities and are doing home visits, they really see the manifested lived realities of how social determinants of health show up in people's lives and then, downstream shape their health trajectories. And so we also knew anecdotally that how people think about social determinants of health and their working definitions of this, so how they use it in practice, may not be reflective of the official definitions. There's lots of social determinants of health definitions out there, but where we weren't sure in terms of, how that corresponds with how people use it in practice. And so in terms of what we found, nurses told us that they did view social determinants of health as important in shaping how they delivered care and the health outcomes of their patients. However, we confirmed that there's a wide variability in terms of how people thought about social determinants, what they counted as social determinants. Importantly, how they documented this really varied, and where they documented this in the EHR really varied. So you can imagine kind of the complexity this introduces if we are trying to incorporate things like social determinants as predictors of health outcomes. We define them in different ways, and the ways that those are defined may not necessarily show up as we think in the electronic healthcare records. And so, thinking about the different categories of social determinants you could potentially capture and the ways that these could be stated and captured in an EHR can be quite complex. So kind of a next step in that study is then trying to extract those social determinants terms from the narrative notes. And you can see, this is one example of an activity that we then went back with the nurses to build kind of synonyms for these words. So we'd ask them something like, what would you have to read in a text note to understand that a patient experienced a language barrier? And they would kind of give us these words. And so we're using this in addition to kind of standard definitions of SDOH to try to come up with additional understandings of how SDOH might be captured that maybe is not so obvious. We're employing kind of a similar method, looking then at the concept of compassionate care. So we just completed the qualitative collection for that. But just to say that, compassionate care, again, is another complex concept that we want to go towards, but don't necessarily understand too well. In terms of the narrow view of equity in the AA pipeline and balancing fairness and performance, Lizzie had already spoken to this model, and this is just to say that, my interest is really closer to the human and systemic biases, as you may have gathered. I won't go into these for now, just being mindful of the time, but really thinking about, where across the pipeline we are thinking about equity, and is that still narrow? So this study, just really briefly, we looked at this trade-off between fairness and accuracy performance in kind of a pre-processing step of one of the studies that we did. And in particular, the choices, so kind of the human choices that the team made around grouping of predictor variables and what effects those had in both accuracy and performance. Using 2 community electronic health records, we tried several different classifiers to see their performance, and then assessed against 3 different fairness metrics to see kind of, again, the performance and trade-off balance. And what we saw, just mindful of the time, so I would kind of jump through this a little bit, is I think one key takeaway from this study was the finding that our choices as a team in terms of how we group the language code. So this was a highly dimensional data source. There were like 239 language codes or something. So we had choices in terms of how we wanted to group these, and then also wanted to know what impact, if any, that would have on accuracy and fairness. And we did see that it did have an impact on accuracy and fairness in terms of grouping language codes, but interestingly, it minimally impacted performance. So a key takeaway here, again, is kind of paying attention to the human roles along the way. And this is, not a new concept for anybody that's worked in stats in terms of impacts on outcomes. And then finally, thinking about factors beyond the technology as well. There's evidence of the importance of diversity, both in terms of the team composition, but I think more importantly, in terms of perspectives that are included. As my colleagues have stated, this work has to be interdisciplinary for us to be able to spot those barriers, those opportunities, those things that we may have blinders to, but having more perspectives at the table allows us to get a better chance at getting, or at least identifying, some of those. So in terms of moving forward, I still go back to this paper that we wrote some time ago, reiterating the points of my colleagues, as a baseline, understanding our role as clinicians in shaping the evidence or the data sources that then shape downstream possibilities, the meaningful involvement of nurses from the start, acknowledging our roles as data shapers and curators and knowledge workers. AI is not going away. In this study, we're still not really that involved even in AI technologies that are developed for nurses. And so that really needs to change. Importantly, I think leveraging diverse knowledge sources and, again, perspectives. So this group is an Indigenous AI group here in Canada that are applying kind of Indigenous ways of knowing to understanding and implementing AI. So I will wrap up there. Thank funders and my team for the opportunity to get this work done, and thank you all for the invite here.
I am feeling so honored to be able to have heard these talks today. So first, I want to thank all of the panelists for their contribution, and then see if we have a minute or two, and I know folks might have to drop off, but if I have a couple minutes to ask Charlene and Liziane questions for them. So Charlene, I'll start with yours. So given the sort of historical inequities that have existed in the healthcare system, and knowing that some of these AI tools are built on biased data sets, how can nurses work to build trust with patients that when they're using AI tools, that they're doing so in fair and equitable ways?
Yeah, I think I think about this question a lot, and I think it does go hand in hand with nurses advocating for the inclusion of data that are relevant to nursing in these. So I think part of it is kind of managing and acknowledging the kind of societally shaped nature of historical data, but then also from that moving forward and advocating for like how should we be collecting data? So stuff like the studies that Max is doing, I'm thinking in particular of collecting, like identifying all of the clinical information that is said but is never captured, providing the evidence base as to like, hey, this is actually the relevant data that we need to capture, and how do we then build systems that are able to do that? So I guess in terms of building trust with nurses, I think that's like where the nursing expertise and relationality happens as well, right? Being able to recognize that like, okay, maybe this model is, I know the training set doesn't reflect what my patients look like. And so the nurse almost as that translator, or you have to be knowledgeable enough to be transparent about then why it isn't reflective of your patient, and then what does that mean then for your decision making. So I think that kind of navigating those conversations, I think, is the big piece there.
Perfect. No, thank you. And then the parallel one actually matches with what I was going to ask with Lizzie Ann. So, we think about translating sort of, and again, going back to the appreciation of uncertainty in decision making, and AI tools will always include that. And explainable AI making strides and thinking about how to make what's going on in the model more transparent. But I'm thinking about for a nurse who has a patient in front of them and is using an AI tool, but that patient might have a rare condition or multiple comorbidities that make them incredibly complex, or certain demographic factors might not be showing up in the as represented in the data set. Just wanted to sort of think about ideas you have for someone sitting with a patient. How can you envision an AI tool might communicate those things, communicate those uncertainties to a nurse?
Thank you for the question. This is a very interesting question. We were just discussing similar things this week because it's most of my research is a very complex population. And I think that is a lot about how we deliver decision making. So how do I envision that happening? I think we will have models, personalized model that could be delivered, like deliver personalized recommendations based on that patient profile. I think that is the first question. That's the first thing that I'm sure is possible, because we do that when we build personalized models. However, I think at that point, the way that will look like at the bedside when the nurse is with that output or that proposed recommendation in place, we'll have different scenarios or different options. For example, I will use my case because I'm more used to talk about this, and I can see that more clearly. For example, I'm discussing with a patient whether the patient will be listed or not for transplant. And there are several outcomes of that discussion. The patient can be listed, can be not listed today, can be deferred for reevaluation in 1 week, can be deferred for evaluation in 6 months, can be postponed because of other reasons, can be approved, but needs to meet a certain requirement before that approval. So there are several, it's a messy decision making, and we have those decision making every day if we think about when we are taking care of our patients. What we don't have nowadays is when we talk with the patients and deliver this message, a way to say, if you take this road, because many of these roads will have probabilities of going in one direction or not, and many of them will need engagement from the patient. And I think that information is what we need to deliver to the patient. If you do this and you take this road, you have this probability of getting there, right? And we don't have those things nowadays for most of our complex cases. And I think that is where AI can help us to better summarize these options in a way that patients can can decide by themselves if they want to go here or there, and that decision will be based on what is the uncertainty in going this direction or not direction or that direction, and they can evaluate whether they want to go or not, right? Some patients will may say, no, I prefer to have a 1 month certainty in going this direction, or I will go to this road that will take more uncertainty, but I will take 1 year road, right? So that is how I envision that happening in the real world when we will have these more complex models available for these complex conditions.
Perfect. No, thanks so much, Lizzie-Ann. And again, just wanted to thank the School of Nursing for helping host this and all of the panelists for participating. I hope you got out of it as much as I did, and thank you for attending.
Thank you, everyone.
Thank you.